Good day, everyone, and welcome. It's a real privilege to me to welcome you on behalf of GCE for this year's celebration of the clinical engineering, the Global Clinical Engineering Day. And a special word of welcome to our guest speaker, Mr. Judd, all the way from America, joining from there. We are looking forward to his shared wisdom a bit later on. Before we start proceedings, can I maybe just ask everyone to check that your microphones are switched off and to keep it off during the duration of proceedings, unless there's something that you need to add, or especially in the Q&A session. And yeah, so I think clinical engineering is I just want to give me a second. Technology is working against me again. There we go. Clinical engineering is one of those professions that if you do it well, then it most possibly you won't get noticed or recognized for it. And I think to quote, or not to quote, but it was mentioned by one of our SAFI colleagues at one of our conferences, Mr. Denton Smith, that you compared the engineering services of a hospital or a healthcare facility to the human colon, and he said that while it's working properly, you don't know it's there, and you don't even know of its existence. But the moment it is not working, then you are in real deep shambles, and that is in our world as well, where that clinical engineers are playing a vital role in providing quality, cost-effective healthcare to our communities. And I think it's basically clinical engineers, in my view, is the superheroes working behind the scenes and making things happen, and not always being in the forefront, and where you can see, and where all the almost want to say all the credit is going to. So I think in that regard, it is the Global Clinical Engineering Day is providing us a platform to celebrate our existence and the role we play in the bigger healthcare fraternity. I think before we get into proceedings, maybe if you can just allow me some time to thank our Gold corporate members. It's due to their continued support and of both GCE and the clinical engineering fraternity in general, it's possible for us as clinical engineers to make a difference. And a special word of thanks to our gold members, including Reef Consulting, Secure Health Solutions, Carl Stort's Endoscopes, Mindray, Meralt, Fresenius Kabi, Safmed, Vamed, SSEM Tembu, TechMed, and Medicare. Yeah, again, our appreciation. I think your contribution is making a difference in, to GCE and then to the clinical engineering fraternity in general. So in today's lineup, we are going to conclude our clinical engineering value add initiative competition. I'm going to park it for now. Later on in the session, we will announce the winners and give a little bit more information about it. And then, it's our main our keynote speaker for the day is Judd. He's the He's going to talk about the universal challenges that affects clinical engineers, looking at some of the common factors like what changes can we expect in the next 10 years. I think we are living in exciting times, and yeah, the change is going to be fast and furious, but exciting. And also, how do we attract and retain the best talent, and how to grow your CE career and your society. So yeah, we're looking forward to that. Maybe before we start with the presentation, just some background about of Tom. And so Mr. Thomas Judd was IFMB Clinical Engineering Division Board Chair from 2018 to 2022. Since he was appointed as the IFMBE Secretary in 2015, the Clinical Engineering Division has grown to a team of over 550 health technology leaders from 200 countries, working closely with the WHO to facilitate access to medical devices on a global scale, particularly throughout the COVID-19 pandemic. In the past 3 decades, Mr. Judd served as a WHO advisor in numerous programs on health technology management. He developed a 1-week advanced clinical engineering seminars in partnership with the WHO in 1991 that resulted in 50 programs with 4,000 participants from 75 countries. He also co-led the health technology management input to the latest editions of the WHO Compendium for innovative technologies in low resource settings. During 25 years with Kaiser Permanente, he devoted half of his KP Georgia's Quality and Patient Safety Director and half as KP's National Clinical Engineering Project Director for 14 million patient, 40 hospital system. Since 2017, he has been associate editor, HD Health IT and Quality for the Permanente Journal and KP Physician Journal, as well as the editor for the Global CE Journal. He has a bachelor's degree and a master's degree in aerospace engineering from the US Naval Academy and the Naval Postgraduate School. He also obtained a master's equivalent degree in biomedical engineering from the Johns Hopkins University. So with no further ado, thank you, Tom, for your willingness to share your thoughts and ideas with us. And I think maybe just on a practical note, Tom recorded his talk and sent it to us. So it's a video that we are going to play, mainly to mitigate the potential risks or problems associated with trying to stream the video over several networks across the countries. And then you're more than welcome to send questions or to put questions in the chat box while the presentation is playing, and then Tom can answer it in the chat box, or we can cover it in the Q&A question session afterwards. So with that, thank you, Dieter. Over to you.
Hey, good day, everybody. Tom Judd here. From the Global Clinical Engineering Alliance, and glad to be with KISA, my South African colleagues today, and to have the honor of presenting this information. So Global CE status here on Global CE Day. It's October 21st when this is being presented, and just a few days earlier than that here over in the other side of the pond. And also thankful for the opportunity to work with IFMB Clinical Engineering Division the last 7 years and chair the last 4 years up until June, when the wonderful Fabiola Martinez became the chair, and I get to mentor her and be a liaison between the two organizations. So today we're going to talk about what's going on with global clinical engineering. Well, first of all, just a quick overview of what I'm going to talk about. You know, CED and GCEA together, Global Clinical Engineering Alliance, IFME Clinical Engineering Division, are the global clinical engineering community. You are part of the global clinical engineering community there in South Africa with KISA. And I'm so thankful for KISA's great work over many years and your desire, as we've heard in recent meetings with the Africa region, to the Pan-Africa region, that you can really, through Mohammed Berra and others, you can really lead and help a lot of societies across sub-Saharan Africa, and you can do that with our help in the global community. So I'll talk a little bit about who we are and so forth, and why we're learning and sharing global best practices. But what's new? What have we learned, particularly in 2022, from several sources of information that I'll be talking about here at some length? Body of knowledge, body of practice survey, the latest version, last in 2017. This new survey around impact measurement. We've had so many best practice webinars during the COVID period, over 60, many of them partnered with WHO that you can find on our websites. Of course, last year was, you could say, the best Congress yet, 128 countries registering, and 200 presentations, over 250 people involved with that. And then Global CE Day since 2015, and a lot of information there. So what are we learning from all that, and some other materials that are available? Well, first of all, I think you're aware that two entities partner together to lead the global clinical engineering community. One is the Clinical Engineering Division, now led by Fabiola, as I mentioned, and the Global Clinical Engineering Founders Alliance Founders Council, led by Dr. Judd David. One cool thing about CED, the new CED board, is that it has representatives from each of the WHO-defined regions of the world. And then many regions are all, from Africa, for example, Ashnafi Hussein, who, of course, was leading the working group on Africa activities for several years with several national societies, and is now leading this emerging entity called the Pan-Africa Clinical Engineering Federation. And then on the Founders Council, you're on Malad Paluta. And what else could I say about this? I think that's perhaps enough for now. All right. So these two entities, they partner together, and how do they partner together? Well, CED has a focus on bringing individuals into our board and collaborator group there. And because of COVID and because of our global clinical engineering response to COVID, we grew to just under 600 collaborators from 200 countries. CED focuses on those individual health technology leaders, biomedical engineering leaders, clinical engineering leaders in the countries, whereas GCEA focuses on the national societies. But together, we're a much more powerful entity than separately. And GCEA, many of you know, has been around since 2020. Actually, first thing out of the box, since GCEA had the ability to transact with WHO and around the compendium of innovative devices for low resource settings. And we've done that the last couple of years. And we went to CED's network through GCEA, leading that effort, Dr. David and myself having that privilege. But we went to the CED network of people to get input from over 50 countries. So working together now for the last 3 years. What does our footprint look like worldwide? We pretty much cover the world is the answer, as you see on this updated slide for this month. What are some of the main things that we do together? And the answer is the Global Clinical Engineering Journal, which is going to show up here, I believe, in a moment. I'm hoping so. Which started in 2018 and has had this amazing impact on our profession. Slides hung up here a little bit, but we'll see what happens. See if I can encourage it. So besides the many journal entries over the last couple of years, here we go. Actually, since 2018, really over the last 5 years. We've also been doing a lot of projects at the global level between CED and GCEA. that here's this really cool slide about all the incredible work of the journal. And we've also been doing many, many projects, and I'll tell you the ones we focused on here in 2022. Here we go. But it's all been about what you've asked for. It's all been about global recognition, building capacity in the countries, and professional exchange. And now we're connected, as you heard, CED and GCE together to 110 national societies. And we're very proud of the awards process that we jointly put together. All right, there we go. Another thing that we've been about, just talking background here before we jump into global status, is that, you know, in the last 3 years, particularly around COVID, that we created this knowledge network that had at least 5 arms so that we basically share global best practices around the world. And we had over, it says 50 plus, but with WHO over 50 plus, and then you add in GCEAs and so forth, we've had over 60 best practice global webinars. In fact, today, as I record this, it's October 12th. GCEA has a program on MRIs, everything you need to know about MRIs, selecting and supporting those. Of course, the CED collaborator meetings, where we averaged over 50 countries in recent years, the putting forward Adriana's WHO Medical Devices newsletter that we share with over 200 countries every time they come out. Our, you know, we've got a WhatsApp group that several of you are on that has experts around the world solving problems on a daily basis. And then perhaps one particular star that in the crown here is that we've had over, since late March of 2020, over 650 Monday to Friday e-newsletters giving you latest information about all the literature coming out that's relevant to clinical engineers, called the Hacking COVID e-newsletter. You know, in the midst of that, what have we tried to share in the context of best practices? What has been the global CE community's results the last 3 years, as we've focused, as you see at the bottom, on all the system issues around managing health technologies that you're involved with every day. A friend said this next slide, as busy as it is was too busy, and I put more in the appendix about who is on all these roles. But you know, in 2020, and particularly out of our Congress in late 2021, we said, what are those key things that we need to work on moving forward? And one is, how do we help countries wherever they are in the spectrum and in their development continue to build capacity, the right people with the right education, training, and appropriate skills. And you know, we've created a new model to try to illustrate that. We've got a project team, not listing all the people on it now, but it's led by Frank Painter from the US, Baron from Nepal, Fabiola from Mexico. And we brought in people with several perspectives in terms of hospital-based, health system-based, Ministry of Health-based, academia, industry, those that have an understanding across a region of countries, and WHO contacts and so forth. In the context of, if you have the right capacity or you're at some place on the capacity building scale, what have the outcomes been? You know, we know the clinical engineering measures, you know, of downtime decreased, and you know, devices cost managed, and all these sorts of things. But how does that fold further down the line to, well, patient lives saved, length of time in the hospital reduced because of health technology? So we've leaned on a new model and a team called the Theory of Change model to work on that, to see how have we improved with various clinical engineering work, access, quality, safety, coverage, efficiency, and other measures like that. And that's led by Antonio Hernandez, historically from Colombia, but from the US, and Pajo in recent years, Shauna Mullally from Canada, and George Baudou from Ghana. And then if we say to the ministers of health in countries, you know, we're ready to serve like we have been in COVID, and like you are in South Africa, you know, they want to know, well, what is your background? What are your credentials? Are you certified? Are you registered? And so we've been continuing to work on that at the global level, and that effort's led by your own Milan Paluta, Ashnafi Hussein, and Fabiola. And then if we've, sort of gotten to a better place on building capacity and measuring our impact and making sure we have our people credentialed and meeting certain competencies and tested against those competencies, we're in a position to help the ministers of health develop policy at the national level. And so we need to, as the notes under there in red say, show value to the Ministry of Health at national level, help write national health technology policy, educate healthcare decision makers, both in the public and private systems, about the best use of technologies. An example is telehealth. At the 2019 Rome Congress, Dr. Elliott Sloan challenged the world to do better about implementing telehealth policy. That was October 2019. We all know what happened starting just a few months later there with COVID hitting. Telehealth became such an important tool around the world. And so helping write policy around things like telehealth is hugely important. And that particular effort's led by Elliott Sloan and Jatinder Sharma from India, with advice from Dr. Manish Kohli. And then since the beginning, the global clinical engineering community has come alongside WHO, of course, led by Adriana Velazquez, and not only her medical device unit, but also this compendium of innovations for COVID, focused in for low resource settings since 2020. And then, this amazing effort developing videos around WHO COVID equipment related training, and particularly about 100 people from many countries led by Bill Gentles and Toby Clark that are now on the WHO website. So how can we come alongside, in your case, the Afro region, how can you come alongside WHO? And there's now representatives of the clinical engineering, biomedical engineering community at WHO Afro that many of you know about. So in other words, our colleagues are in the room there with the decision makers, helping every day. And I'm thinking of Martha Tusabe and Martha Malura, who reside in Uganda, but are part of the Brazzaville team for WHO. So that was all the introduction. How we doing here? So good. So what are the data sources for the input today? And this body of knowledge, body of practice survey that really is ongoing as I speak, but we offered it beginning about mid-September. We'll continue it here for a few more days. Even after this airing here of this presentation on October 21, we will make sure you have the link and can add to this survey. More to come about that, but that really shows the body of practice in different cities, different countries, different provinces, as well as different regions of the world. A newer survey is out there and called Theory of Change Impact Measurement Survey. More to say about that. Of course, we've had, as I mentioned, 60 plus webinars that you can find in a link that'll be available in this presentation. But I think many of you know that if you go to the CED website, which has just been updated, or the GCEA website that's just been updated, you can go to the webinar portions of those and find all of this information. And in those webinars, their sub areas of focus are clinical engineering, health technology management competencies, GCEA, CED partnering with WHO around COVID issues. And in this body of 60 plus webinars, they are in English, Spanish, and French languages. So we're attempting to wrestle with all these different dimensions of best practices to get the word out there. And I know, for instance, in sub-Saharan Africa, certainly English perhaps leads the language efforts, but there's many, many colleagues that are in French-speaking countries in sub-Saharan Africa, for example. So as KISA, as Mohammed Berra has said to me in the last month, KISA stands ready to help the other countries, help develop their programs. And so that, using those French language webinars and creating new ones is certainly one way to go on that. And I mentioned before the Congress last year with input from many of you, and then our country and national society presentations around Global CE Day and Global CE Week, particularly the last 3 years, but we've got information on that, where people have shared their practices for 7 or 8 years now. And then also when I speak today about, what do clinical engineers need to know about where they are and where they are individually and where their country is and where they can go from here, let's think about that in the context of our consensus projects that I've already talked about. And we'll have more to say. New slide. Gonna put on my glasses for this one. A lot of credit to many people putting this model together, but particularly fine-tuning it here in recent days with my colleague Caleroy Staviano here online with me today and helping me get this recorded. So looking over to the left, basically how do you build capacity for clinical engineering, biomedical engineering that serves at the point of care in a country? And I say the answer is through KIC, K-I-C, through knowledge, where the individuals gain knowledge because it's available to them that want to contribute to that, through investment, and that's sometimes beyond our control, but when we're credible, we get people to invest in us, and more to say about that, and through our competencies. So we build capacities in countries through having the right knowledge, having the right investment, and the right competencies. If I slow down a little bit, the subgroups under knowledge are your educational background. Let me call it academia. In the lower, and I've got stratified here, low, middle, and high, trying to make it as relatively simple as I can. In the lower resource settings in several sub-Saharan African countries, the typical educational opportunity offered to individuals in clinical engineering, biomedical engineering is 2 to 4 years. In the middle area of capacity building, it certainly would be a 4-year undergraduate program would be available typically within the country. And then in the higher graded or stratified countries, there would be graduate clinical engineering offered. I mean, I think of the health technology management masters and above program that Milan Paluta offered there at the University of Cape Town for many years. And so certainly South Africa would hit in the high end. And actually, when I talk about this, I'm focused on low middle income countries. We know, the World Bank stratifies countries of, low income, low middle income, high or low, high income, anyway, higher income, middle, and so on. Different stratifies. And South Africa is actually not an LMIC, but perhaps you might say, well, parts of South Africa are LMIC because of their economic status. Any way you want to slice it, and I use the World Bank definitions in some of the material I present today, who's actually a low middle income or LIC, low income country. South Africa is in a position to help others. So when you look at this slide today, look at it 2 ways. Yeah, South Africa is actually, high capacity, but it's in a position to help others. And I'm so thankful for your heart and your willingness to be like that to others and to continue to develop yourself. Anyway, so education, we know that, initial education is way not enough. We have to add continuous professional development, continuing education units. We have to add training. And in the lower setting, that's training in the country is limited. In the middle, it's ongoing, and it's in the high end countries, it's not only ongoing for regular typical devices, which I define as, your patient monitors, OR, ER, general care devices, but it also has training available for higher tech devices like medical imaging, cancer treatment devices, and clinical lab. Knowledge can also be defined by credentialing of programs available, which are certification and registration. I know registration is a big issue in South Africa, for example. In low settings, lower in capacity building settings, that's absent, and middle limited, and in the high end, more and more people are getting certified. And then we have to say, a new area of knowledge for clinical engineering, biomedical engineering, serving at the point of care is digital health and innovation. This is the knowledge, as the information says here, used to improve devices and clinical and business workflows and more. And that's typically absent in low and limited in the middle, and it's beginning at the high end. I know there's a lot of, we had best practice webinars from our African colleagues about building infrastructure across countries and across that sub-Saharan African region for digital health tools to be used. So anyway, knowledge, education, training, credentialing, and digital health and innovation. The next bucket is investment. Do you have a a unit for medical devices and health technologies at the Ministry of Health or Department of Health level. And in the low settings, it's externally driven. NGOs and industry drive health technology development. In the middle classification, you're now having a Ministry of Health unit that directs investment. And then in the higher end, you're Ministry of Health driven, and you also are working with your industry and university partners as well. Where are devices coming from that, in terms of investment for the country and health technology? There's some countries around you nearby that are driven by majority donations, as opposed to the majority private health leaders or Ministry of Health leader driven that are invested in purchase within the country itself. So in the low end of the spectrum of this framework, it's majority donations, and I've been to those countries. Maybe some of you have as well. In the middle, it's now you do have that Ministry of Health unit, and that's leading the health technology management activities, planning, selection, management. And then in the higher end here, extensive in this framework, extensive planning, selection, management through Ministry of Health. Is there an investment in CE departments in individual public and private hospitals with facility available, space and test equipment? So once again, limited on the low end of the framework, countries and their capacity building capability. Full range of typical devices in the middle range, and extensive facilities and test equipment for higher end, higher tech equipment at the high end in this framework. How do you manage inventory? What's the investment in that? Is it manual versus computerized medical maintenance systems? And at the high end of that, for example, that includes digital health and cybersecurity information. And then when people are investing in health technology and capacity building, they add also quality and safety activities, added value activities around measurement, monitoring, improvement, and risk management. And that runs the spectrum from absent in the low end to extensive in the high end. Again, competencies quickly here. The scope of the clinical engineering health technology management activities, it's around a minimal set of devices in the low end, full range of typical, and then at the high-end countries in this framework, they also manage in their scope high-tech devices and digital health tools and cybersecurity. What's the focus of their support? It's limited up to a full range. Other competencies, and you remember we had about a dozen of those from our webinars 2 years ago. What kind of clinician and healthcare team relationships? How well do we partner together with other healthcare team members, either from absent to strong partnerships? Is there a presence of a national CE BME society where we bring colleagues together to share best practices and training? Absent to mature and able to assist other countries, that's where GCE is. And then involvement in the competency areas. Are you involved in policy, regulation, and legislation as a profession in your country? Raising health technology issues to the national level, as it says. So that's from absent to extensive. I mean, early in my career, I was the clinical engineering director of a hospital, of a community hospital that took care of adults down to children. So kind of a comprehensive 500 bed community hospital. But even though I had, quote unquote, all those resources going for me and that investment, and hopefully I had the knowledge from my background in education and training, and I was a certified clinical engineer, digital health wasn't on the table yet. There back in the late 70s, early 80s. I still needed colleagues to share best practices of what they were doing about this or that. And so we did create a local society in that city where I lived. And later we created, and we needed to know more than that. So getting together with colleagues, encouraging one another, getting training, and so forth, telling people where other places to get training and knowledge and, educational opportunities within the city and so forth where we lived. We outgrew that. We needed to grow into the state level and what we call in the United States, of course, which may be the provincial level in South Africa. But we needed to, and eventually I became a part of the American College of Clinical Engineering, which was a national group and did work outside of itself. But, we started ACCE started advanced clinical engineering workshops to work with developing countries. My point of all that is societies are there to help one another grow, and it takes a while to get started. We need all hands on deck to work together to continue to grow. So, all right, Tom, I see this framework. You've gone over it a bit. Nearly halfway through my presentation, but really this is a hallmark of one of the things that we're offering today, where you can help see where you are, you can help countries around you see where they are and identify gaps and certain competencies that need to be added, and you can help others grow as you reach out to other societies and other countries around you. And by the way, in sub-Saharan Africa, in this new emerging Pan-Africa Federation led by Ashnafi and assisted by Mladen Paluta and Kisa, you got a lot of that work to look forward to that helps you individually grow, helps you as a society grow, but helps other societies and other countries around you be sustainable. We heard from many countries. There's about 25 countries in sub-Saharan Africa that have been active in our work, and another 25 that are a little bit beyond the reach, I would say, of active. But so you got a lot of neighbors around you that are at various places on this spectrum, and you can help them grow. And while you help others, that you grow as well individually. So how do you move between levels? Well, we believe that if you don't have an academic resource to get the academic training you need, education you need in your country, then you're probably in a lower setting. But so you might have to go to the next country over to get the academic resource. And so that would be how you would grow in that aspect, or in the attribute of knowledge. You would grow by having an academic program that assists clinical engineering or biomedical engineering, health technology management in your country. And then if you wanted to move from a middle country to a high, you would have more training and certification programs available. So those would be how do you know where you are and how you need to move in the right direction in terms of knowledge. In terms of investment, if you don't have a Ministry of Health or Department of Health, in the case of South Africa, a health technology unit, you're probably in a lower capacity position. But when you start one, then you're now in the middle already. And then what does investment look like when you move to a higher capacity country? It would be investment in certain improvement activities around quality and safety. So these are ways you can move between stages, and you can see where your gaps are. In terms of competencies, if you don't have a national society, you're probably at a lower stratus there. If you create one, you're probably at the middle level. And then as you manage in terms of competencies, because you gain more experience and more competencies and higher tech equipment, managing higher tech equipment, you've moved to the high end. Now for developed countries, by the way, and CED and GCE are connected to, as you heard me say before, 200 countries. About half of those are LMICs, according to the World Bank definitions. But even within countries that are not LMIC, they certainly have areas, even in my country, that are not very well developed. So, but for developed countries, this framework is very similar, but it maybe adds a fourth stage, super high or something, I don't know. But you have more advanced knowledge, investment, and capabilities than that. All right, there are some notes here. I've mentioned a couple of them: continuing professional development, CPD, CEU, continuing education units. It's one way people measure CPD in several countries. Credentialing is typically achieved by education, experience, and testing, and it's maintained via CPD and CEU. I've talked about typical devices that are generally found in district or regional hospitals in your countries, with devices like patient monitoring, OR, ER, general care. And then I'll talk about high-tech devices, all the medical imaging modalities, radiation therapy and things like that, cancer treatment and clinical lab systems, and so on. And there's a document that's going to be attached here that you can find more about competencies that we've identified and put into our webinars around best practices. So I'm going to move on, or attempt to. All right, let's see. My computer spent so much time here at this page that it's had to stay for a while. I think I'm going to get there. What the next page is going to show is the body of knowledge, body of practice survey. And I hope we'll get there soon. There we go. Terrific. And as of today, here on October 12th, I think Calroy has told me that there's over 430 responders. What's interesting about that, and that there something like 110 countries have our colleagues have responded. And once again, if you have not yet, please respond, not too late. But that's to be compared to 5 years ago, where we had 35 countries, not 110 responding, and we had about 200 responses. So we've more than doubled the responses, still taking them in, and we've tripled the number of countries. On this little chart that maybe is a little bit of an eye challenge for you, of the 110 or so that have responded so far, 50 are LMIC. And for instance, in Africa, you see almost every country, both in our network and that it responded to this survey. By the way, it's a 5-minute survey. It doesn't take long. Just go to a link and you'll rip through it and you'll help us. But only 3 of 24 countries are not LMIC. Only your own country, South Africa, Namibia, and Botswana. Everyone else, you could read down the line: Benin, Burkina Faso, Burundi, Cameroon, Chad, DRC, Ethiopia, Ghana, Guinea, Kenya, Malawi, Mali, Mozambique, Nigeria, Rwanda, Senegal, Tanzania, Togo, Uganda, Zambia, and Zimbabwe are all LMICs. So you have a, when you think about that framework that I just put up, and by the way, framework is one of Milad Paluta's favorite words, but you see why he loves that framework idea for many things, because it's a very powerful concept behind how we can define where we are and where we're going. But the Americas, about 30 countries responding in Eastern Mediterranean, Middle East, North Africa. We classify countries slightly different than WHO does here, but about 15 countries responding there, typically Arabic speaking. In the European region, nearly 30 countries responding. Southeast Asia, 10, and Western Pacific, about 9 or so. So we're very thankful for this response, but great. Okay, Tom, you had a lot of response. What did you learn? What can the profession learn? One thing we learned is that the profession globally is pretty young. I'll show some more details of that, but more than half of our profession across the world is under 40 years old. I'm really, as a gray head myself, I'm very thankful for that. Most of that, the next item goes along with that. Nearly 50% of CE practitioners, of responders across the world, have less than 10 years of CE experience. So, hey, what a great opportunity to help people build their careers and help their hospitals and their countries. So much more as we build into this younger group. By educational background, 15% are associate degree, 35% have undergraduate degrees, and masters in 40% of the time. In my personal journey, I had an undergraduate in aerospace engineering, was able to get additional master's level work in biomedical. So, we come from different backgrounds is my point, but we are all sort of aiming at, managing health technologies at local and national levels. 2/3 of the respondents needed credentialing opportunities, registration and certification. 80% of those 2/3 said it was required in their country to be viewed as the professionals that they are and to make the contributions that they want to make. So, more in credentialing. And, what's changed since the last survey? We obviously tried to not change some of the questions in the survey that was last done in 2017. But the global growth of digital health and our involvement in digital health is the biggest change the last 5 years. Can I say something about regional differences in the survey, like the body of practice in Africa? And I'll try to in the coming slides here. Once again, a lot of information. I'll share a little bit about it and let you reflect on it later. but globally, the ages, and I'm showing some regional differences here with the global versus the Africa region. Globally, 20 to 40-year-olds are 50% of our respondents. In Africa, 20 to 40-year-olds were 71%. So a big jump, a younger practitioner group there in Africa. Globally, 25% of the mix of the respondents were 1 to 5 years in the profession. In Africa, 45%. So once again, an opportunity to make a difference in your region. Globally, in terms of background, 13% associate and 35% had undergraduate degrees. In Africa, 31% associate and 44% undergraduate degrees. So picking up where we left off, we were looking at the regional differences from this Body of Knowledge, Body of Practice 2022 survey that's ongoing here. So globally, we see that 70% identify of the respondents as clinical engineers and biomedical engineers, about 15% as technicians globally, and 15% as professors. In the Africa region, only 50% identify themselves as clinical engineers, biomedical engineers, 17% as technicians, 22% as technologists, and 9% as professors. So we're not going to jump into all the differences there and all the terms. We have those defined in the survey, and you can see that and check that out. In terms of global digital health, everybody knows they need it. What are the top 3 areas that training is desired as we move forward? Globally, it's interoperability, 38%, cybersecurity, 24%, robotics, 24%. And in Africa, a little less on interoperability, how we connect electronic medical records and other data systems, 21%, about the same on cyber, about 22% robotics, the same, but decision support about 12. So, I don't know that digital health is fully understood by the, 25 countries that are participating in here from Africa, as well as we might yet. So more to come. Globally, as it said, of the 2/3 that don't have certification programs, 80% of those feel like they need it in their countries. And in Africa, 90% need certification. Next slide. So this is a tricky one, but trying to tease out from global and regional data across many sort of competencies and skill sets, what's different about Africa. And in HTM, there's a similar time focus at the bottom there to the top of for global versus Africa for service delivery management. More focus on service delivery, more repair focus among the practitioners in Africa, sub-Saharan Africa, less time on evaluation in Africa, less focus on digital health, more focus on education than globally in Africa, more focus on facilities. This aligns with things that people like Milan Paluta and Mohammed Barrow told us in the past, of how management needs to take place for medical devices in hospitals and clinics in Africa. More focus on risk management and more focus on general management. So in other words, I think that the busyness of today and the equipment around us takes more focus and less time maybe for emerging topics and so forth. But country by country, this data would be of value to you. It's kind of hard to see all these trends, but this is a first analysis. Next slide. All right, so overall, where do we think we are with the survey analysis and how it contributes to capacity building strategy in a particular country or countries that you're trying to serve around you? Well, we can utilize the framework that you saw a couple slides back and the results, and we can share the data, it'll either anonymous or, by country, we can share the data in an appropriate way so that we can drill down on that. But know where you are on the framework, know where your country is, and it can help you personally or your country or your society or the countries around you determine where do you need to focus to grow, where are the gaps. You can recognize regional differences in setting strategies. You can begin to develop more awareness for health leaders for capacity building through WHO and its regional offices. So let's say you're working with the 2 Marthas and you're working with the Afro office. You can dive into this data and see where you are and where you need to go, you can use WHO's training videos. You can develop your own regional and country webinars using this body of practice, body of knowledge criteria. You can use online training. There's some of these tools already available, some of these videos, some of those that we can develop with you, with our KISA and perhaps CED, GCA can develop, for local use or for your country and the countries around you. It's always in our profession been about identifying and working with key healthcare influencers, either from academia or other professional groups, industry, other health services leaders in the private sector, to drive awareness and influence with those health leaders. So we can share our findings, address, it's always important to address their priorities, the country's health priorities, not just our clinical engineering priorities. We can help strategize with this information about finance and funding strategy, and we can figure out how to partner with universities around these kinds of activities. So there's lots of things we can do with all this new data, and that we'll be happy to share with you. Next slide, please. All right, the theory of change survey. This is particularly around impact measurement, and it's talking about moving past just our normal clinical engineering measurement indicators to how does that downstream affect the health systems in which we work. The survey is found in that link, and there's a workshop from August that I think Shauna Mullally was talking about how to use the survey, but it's really measuring how, once again, how our clinical engineering activities, you see in the upper right of this slide, create certain outputs like less downtime for equipment, but how does that affect patient outcomes, and what kind of impact does that have on your hospital and the health systems in your country as you measure through that around access, to improve access or quality or safety or efficiency. And you now have to add in the context of digital health and cybersecurity into this discussion. So we need to learn how to tell our success stories in the context of their impact further downstream on health outcomes. And the global clinical engineering community has a lot to say about our success stories, and how we changed indicators, locally from our 2018 article in the Global Clinical Engineering Journal on success stories from clinical engineering, 400 from 125 countries. And there's more success stories recently that we can share with you. So, and there's many success stories and best practices shared in those 60 webinars that are on the CED and GCA website. So, there's a lot we can do in this area. This is probably the biggest, we've done the least, and we need to do the most in this particular area. But as you tell your success stories and the impact, you have to look at impact on health outcomes locally and regionally. And they, says demonstrating impact on small and large scales all are equally valid. Maybe you made a change at your hospital and you just changed the outcomes of your hospital. Well, let's aggregate those wherever we might and tell them across a province, so that we can say in this province, the public hospitals or the private hospitals are making a difference in the following ways, and raise them up to the ministry level. And we want to align our work with how WHO, talks about its priorities around health technologies, like for affordability and access, or around maternal and newborn health, or non-communicable chronic diseases. So we need to align our work with how WHO looks at outcomes. And there is a document we can share from the Americas region, Antonio Hernandez had from about 30 years ago, that shows how we've been able to measure impact over history and how that was done. And a link will be provided to that document. Next slide, please. Credentialing, that we've been working on this for a long time. What will be the global clinical engineering community's focus? We think it's going to be more focusing on certifying regional and country certifying bodies rather than creating our own for individuals. We will assist the individual part, but it's going to be more of a focus on, what's the right way to check the competencies of an individual or a group of individuals. And one of the things, the pictures you see on this slide are the program in an existing program in India that's highly successful, particularly during COVID, where they had a certification program in maintenance, biomedical maintenance, and another one in biomedical engineering, which is really clinical engineering in this case. And those are set programs with set testing and training connected to them that leads to a certification in that country that was immediately put to use in the COVID era. So, and there's set programs like that in the US, and there's set programs in a different kind of program there in Japan. But we will help you connect to the right programs that make sense for you. And in the context of that, how can what have we done lately that helps that? Well, we can look at the body of practice of CEs and CE practitioners using this new survey that I was just showing you so much information about, and how that can help create certifying bodies in your country or region. Maybe KISA can help do this, help lead a certification program for sub-Saharan Africa. I mean, all of that's on the table, and CED, GCA want to help you do that. Certainly, we need to be using the data that we have to set norms, global norms for CE practitioner types. What should clinical and biomedical engineers know to do? What would CE HTM managers or technologists or technicians know to do? If you were good in digital health, how would that be measured? Could there be a certificate for that? So, and we can, it's Mladen's idea, and I heartily agree with it, is, let's hold regional webinars to clarify regional certification plans and needs. One thought that's gained some momentum is creating a competency exam that maybe 80% of it would be global, and the test questions would measure competencies for that, set of competencies that are not changing really from country to country, but there's 20% of what the exam would be about that would have to be created locally because of differences in practice within a country. And then perhaps like a society like KISA could administer the exam not only for your country, maybe for the region. Next slide. So obviously I'm talking about how all these data sources coalesce into our projects and what we can do next related to all these consensus ideas, consensus priorities. Policy. One thing is Dr. David and I had the privilege of working with many of you in creating a editorial at the national level in the US. So this is the National Academies of Science, Medicine, and Engineering, and the National Academy of Engineering published a editorial that Dr. David and I wrote in May of this year, The Growing Role of Clinical Engineering, Merging Technology at the Point of Care, that you can go check out the link about that. And you can check out some notes that are available in this document that can be opened from this page, that where Dr. Manish Kohli, who a physician who has done a lot of cool things around the world, says, hey, if you want to get the ear of the Ministry of Health and set policy, you need to think about, what is the Ministry of Health priorities? What are the health leaders' priorities? And for example, 50% of the spending in healthcare is on clinicians, on doctors and nurses, and other providers like that. Can we change the workflows of physicians and nurses where clinical engineers are more involved in some of those tasks and those workflows, so that the clinicians are freed up to deliver clinical care? Can we help them manage the use of technologies in workflows daily in some fashion? Can our practitioners do that like they do in Japan? 50% of what they do in Japan is the super users of high-tech equipment, for example. How can we involve in better use of that investment in clinicians, that and clinician workflows is one way we can get involved in the policy discussions. There are other things that are said. We need to write national policies, as we've said other places. We need to align with the appropriate professional groups. Maybe it's aligning with the physician professional groups for you in South Africa, but you'll figure that out. And then an example from Mexico, and the references there, the last one is Mexico is very connected to its Ministry of Health. In fact, Adriana in 2004, I believe, started this National Health Technology Unit that's involved in many aspects of healthcare delivery in Mexico. And their work plan in 2022 gives you an example of a policy at a national level for public health in a country, of for managing health technologies. So as you develop your own health technology policy and fine tune it in your country, you want to take input from WHO, and it gives some examples at the national level. What are the health leaders in your country? What are their priorities, and how you can write that into health technology policy, like telehealth we were talking about earlier. You can utilize available case studies, and there's some very relevant recent ones from this Every Breath Counts coalition that the clinical engineering community has been involved with since 2020 around COVID issues and oxygen issues. Certainly you want to look at the Ministry of Health perspectives, particularly around workforce and investment. And then, we've got colleagues that have used policy to merely as a springboard to make a change in healthcare delivery in their country, like it's happened in India. So you can validate in policy, what does South Africa need versus what Malawi needs versus Kenya needs. You can validate that through the regional differences from the survey findings. And then you can begin to pilot some of these ideas, and in healthcare delivery. So next slide, as I wrap up here. And of course, don't forget about our WHO collaboration work. This is showing a screenshot from the WHO Medical Device Unit website that Adriana's put together. And, so what's different today in 2022? Well, we have CEs and biomedical engineers on staff in several of the regions of the world. We're very involved in WHO's initiatives like around nomenclature. I think Martha Malura and Martha Tusabi particularly are working on a HTM survey within Africa region, and you can come alongside and help her in some fashion. You can use the medical device database Medevis around additional training and updates that are going on through that website that's available for WHO. There's a new strategic group around medical devices that's still in the midst of forming here today in October of 2022. But this group will set strategic next steps around medical devices globally and within the regions. So that's a new entity, a new evidence that Adriana's work is paying off at the global level there in Geneva and beyond. You can use the training videos that came out this year that I spoke about earlier around COVID things to train your colleagues, to train other allied health professionals and clinicians in your country and your ministry units. These are tools that they would want to have to manage COVID, and it's very important. You can check out the work that CED, GCA do around this innovation compendium that I spoke about earlier. And you can continue to work with innovation issues with WHO at various sources there. Next slide, please. So where does this lead? This is my last kind of official page. You say, great, Tom, you've been throwing a lot of stuff at me here. What does it matter for me? Well, first of all, recognize, GCA and CED are out there. We've got these new websites that are getting better and better every day, that showing you screenshots from those. So I'll slow down and say the pandemic has made our profession more highly visible globally. I think many of you know the stories that at the 2020 and the 2021 World Health Assemblies is when like 194 ministers of health from WHO's member states come together, either in those cases 2020 and 2021 and 2022 came together hybrid, came together on Zoom. But when they came together, what were they talking about? In 2020 they were talking about ventilators. In 2021 they were talking about oxygen sources. So we know that, and they continue to talk about various health technology needs here in 2022. So we are highly visible. How can we make a difference? We've got the ear of the Minister of Health. We've got the ear of the health leaders. We've got to share with them our locally relevant clinical engineering best practices coming from all those webinars and those other sources I mentioned. We need to help those health leaders, now that we've got their ear, now that they know that we're there, now that they know we have answers, we need to find the solutions from all of our mix of information and share those with them, and CED, GCA will help you do that. So let's take advantage, let's let this crisis not go to waste in terms of it's an opportunity for us. We didn't let it go to waste. We worked hard and we made a difference, with the best information we had, but we can do better, we can do more. And you can connect with your regional health leaders, your national health leaders through your society to figure that out and work out with your global colleagues what it is, how we can communicate and how we can get more involved and how we can make a bigger difference and bring more recognition to our profession. So your country's clinical engineering status. These data sources have shared many best practices for competencies and COVID-related solutions. Go look into that. Find out the ones that you think you need. Maybe we can set up through KISA some sort of question and answer. We can use the global WhatsApp group that I think Mohammed and Mladen and others of you are on, to ask questions. So, okay, the data's out there. How do I connect it to the need that I have locally? So, and because the best practices have been shared, there's a lot of information, but how do you dive into that bowl and pull out the ones that are relevant to you locally? These 5 projects that I talked about address our top global CE concerns and opportunities. So once again, look at those and see what we're doing and see how that affects you personally and your society, and how you can use information that's available to you now through our various networks to help solve your problems and to take the next steps in your careers and so forth. And then you consider this capacity building framework that I spent a lot of time on. Analyze how your country fits in, prioritize what gaps you want to pursue, maybe personally as well as for your society, and work with your partners like us, GCE, CED, and KISA to determine some next steps. So we have so many tools, we have so much networking, we have so many potential alliances available now. How will you use those tools to grow yourself? And that's my question I'm going to leave hanging with you. And next slide, please. And so thank you, and you know how to contact me, and happy to work with Mohammed and Mladen and others. And let me just tell you what's behind here in the appendix, although we're almost out of time. A quick look at the appendix, Callie. So more about definitions, more about competencies, more about our Congress, Global CE Day and Week, past summits, another survey that led to the development of GCEA, and our project teams, more information there. And so I'll maybe go back up one slide at my thank you slide, and I'll end there. So hopefully I'll be able to answer some questions in real time. Thanks, everybody, and bye for now.
Thank you very much, Tom, for the contribution.
The guy was pretty long-winded, though, Van. I don't know.
No, thank you. Can everybody see my presentation? Is it showing all right?
Yes, thank you.
Yeah, thank you, Tom. Yeah, on behalf of KISA, thank you very much for your inputs here. I think just not only for today. I mean, it's your willingness to invest your time into KISA, we really appreciate it. I mean, it's not only today. You've interacted with us before and shared your knowledge, and I think one thing that COVID also taught us was that it is silly to work in silos. Where there's a wealth of information internationally available, and which can where we can learn from each other and not make unnecessary mistakes. So thank you very much for your contribution. I think I don't know if there's anyone that want to ask a question. I see there is a question from Mohammed about what drove your decision to go from Erudan, what your previous or your starting point in engineering to where you are at the moment.
Even though there is a blog on that, I'll give a short answer. Yeah, I had before I went to university, I thought I was going to go into pre-medicine when I went to university, but at the last moment, I got a appointment to the Naval Academy in the United States. So a naval officer training, 4 years. And so then I shifted my focus from pre-med over to, hey, I want to be a jet pilot. Hey, I want to be an astronaut. I proceeded along those lines for 7 years and found that, first of all, well, when I got to the end of 7 years, I found that, and I was a jet pilot, but I found out at high speed at night that I had some eye problems that had not been detected previously. And it was in the middle of the Vietnam War. I'm not going to take a long time here, don't worry. And I just said, my eyes are not what I thought they might be. Is there another way I can serve both in the Navy and beyond? And so then I said, biomedical engineering was available to me nearby at a great university, Johns Hopkins. And I said, I'm going to go back and teach, systems engineering back at my alma mater, but for the rest of my career after I left flying. I didn't make a mistake, but I still have my wings, but I couldn't fly for the Navy. So I said, how can I serve? And I said, it's very natural with this management background, with this systems engineering background, and my love for medicine to go into biomedical engineering, and the rest is history. Over.
Thank you, Tom. Very interesting. Thank you for sharing.
But I think the point that's relevant to all of us is how did we get into the field? Is because we want to serve other people and we want to use the skills that we've been given.
Definitely. I think maybe just a question from my side. I don't see any other questions. Basically, you've touched on digital healthcare. How do you foresee the future developing in terms of if you think of sub-Saharan Africa, it is resource scarce or areas where there's not a lot of resources, and to get from a low base to a fully digitalized environment is very expensive, and what's the alternative? So what do you think is should the end point be for companies where resources is a problem?
I do see digital medicine, which WHO has embraced, and WHO's main focus is lower resource settings. So I think broadband, will be spread. I mean, it's not only in sub-Saharan Africa, but many other places around the world that have remote locations. I think the ability for digital tools to make a difference in how we deliver care and clinical engineering's involvement with those digital tools will increase. And so I am very not pessimistic. I think digital tools will, and their importance and our ability to help manage them will just grow. So I don't think I'm naive about that. I mean, we've been watching the emergence of these tools for 15 years. I know, Mladen brought various folks, Martin Weiss, and there's others from Canada that have worked across sub-Saharan Africa, and the Africans themselves have said, yeah, that there is more and more opportunity for these digital tools alongside our traditional medical devices to make a difference. So Van, that's the answer I'll stop with for now.
All right, thank you, Tom. Then I see there's a question from Sija. Hi, Tom, thank you. As you mentioned in the survey results, we have a lot of young, eager, and talented clinical engineers in South Africa. One of the common challenges is how to get your voice heard at senior management level, particularly when clinical engineers are typically viewed as general maintenance staff in hospitals. And what practical advice do you offer in this regard?
Sure. I mean, obviously, at an individual level, it's competence, and I'm not trying to be, say something negative or critical. We have to be competent. We have to grow in competence. We have to look for ways to get training, so we can prove ourselves locally to the managers, to the administrators. I think, KISA can play a role in that, as KISA maybe connects with the Department of Health. And in other words, the bosses of your managers, the bosses of your supervisors, your administrators, when they at the Department of Health level, and those Department of Health level see at the WHO regional office, the strides that are being made by clinical engineers, biomedical engineers serving at the point of care. In other words, from the bottom up with our confidence, and from the top down with our alliances and our partnerships and our work, at the ministry level, at the Department of Health level, I think over time, those managers will get convinced that, the clinical engineers have more to offer than they're offering so far. But let me give a quick example, and it's not South Africa, but, there was a clinical engineer from Pakistan who got her undergraduate work there in her country, and I'm talking about Tazeen Bukhari, then got a master's in UK, came back to her country, was serving in strong hospitals. When COVID came, just through relationships and because of her demonstrated competence in her relationships, maybe, I don't know, of her parents and her parents' friends and her own, circle of friends, the Ministry of Health got notice of her in her country, and they asked her to do the WHO countrywide COVID survey. It was really focused on oxygen and respiratory equipment. And now they're asking her to write policy for the country with a team, pull the right team together. And she can't do all that by herself, although she's got a lot of talent, no question about it, like you do, Shija. So she's gathering an international team around her to help speak into that and to share best practices. So I think it's a coordinated effort, so you have this community around you. You have this, let me call it the choir. You're a choir member and all the choir can come together around you. And I think we can sing beautiful enough music so that we get recognized. So I hope that's not just, pie in the sky far away. I think that's something we can all do, like Tazeen is doing in Pakistan.
Thank you, Tom. And I see we are running a bit late, so I'm going to conclude the Q&A session with that. But thank you very much for your inputs and contribution. We really appreciate it. I think the last section of today's proceedings is to announce the winners of the competition that we run building up to the Global Clinical Engineering Day. And I think Tom mentioned also in his presentation about the sharing the success stories. And I think that is in essence one of the aspects that we are trying to build on, or to start to get going with this initiative. So I think over to if we look at the competition that ran, it was basically sharing the value added in clinical engineering via an initiative or a project that GCE members were part of. The submissions had to be in the form of an essay, and then obviously the supporting documentation and information must have been included in the essay. And submissions was evaluated by a panel which consisted of the chairpersons of the 4 branches, and then then there's prizes for the top 4 submissions. I must say I'm quite jealous of the people that's going to get prizes today. It's just very nice prizes. The first prize is a DeWalt cordless compact drill. And second prize is a Leatherman Super Tool 300. Third prize is a Leatherman rebar, and the fourth prize is a Leatherman Wingman. And yeah, so I'm regretting not submitting something myself. If we look at the fourth prize, congratulations, Luvo Jongi Slanti. Congratulations with your fourth prize. He submitted a paper about clinical engineering processes, where he had a look on a look at processes that needs to be implemented to manage the healthcare technology itself, and then also to integrate the healthcare technology to make sure that the envisaged advantages that must come from the equipment is achieved in a clinical setting. So congratulations, Luvo. Your prize is on the way. The third prize went to Mohammed Ganza, and it's a Leverman rebar. His paper, or that he submitted, was about a process that he created or developed to evaluate equipment that's demonstrated by suppliers for use in the facility. And also he looked at in which areas the equipment might be suitable and the suitability in that area itself. And basically a tool to evaluate it in that setup to see if it will fulfill the desired needs or not. So congratulations, Mohammed, your prize is on the way. In second place we have Tim Okai, and his submission was about a clinical engineering online training program, and a lot of work and effort went into that. It's evident from his essay, and he was basically part of a panel or to implement online training courses for clinical engineering. And he, I think, correct me if I'm wrong, but I think it's 110 hours of online training. So I think looking at Tom's presentation as well, there's a great need in our country and in the continent for proper training. And so I think the value add there speaks for itself. So very well done, Tim, and your Leatherman is on the way. Then for the first prize, well done or congratulations, Winston Pariachi. He submitted a paper about also hooking on to what Tom mentioned in his presentation, was telehealth or telemedicine, where he was involved with a group of students from the Northwestern University of Chicago, where they looked at designing an application where support can be given to the users of medical equipment in their daily work to troubleshoot problems and to help with application settings of the device. What was quite interesting for me from his presentation was that a section of the staff members were not very open to the new technology and using their own mobile devices and data to do it. Although it is a great tool to assist them in their daily tasks. So well done, Winston. You are our winner of the competition for this year, and like I've mentioned, I'm quite jealous of your prize. It is very nice, and enjoy it. And I really want to encourage everyone to participate next year in this in this initiative. I think if we share our stories, we can learn from each other and build each other. Then maybe just on the last point about the competition is well done to Cortus and Sija for arranging and driving the process. I think it's a very worthwhile initiative. Well done. In closing, thank you again to our Gold corporate members for your support. Again, your contribution to GCE and the clinical engineering fraternity in general is definitely keeping the ball rolling, and we can't do it without the support from industry. So thank you very much. And with that, I think that is it. Thank you for your time on a Friday afternoon. It's was maybe not necessarily the perfect timing, but taking in consideration that our keynote speaker is from the US with a time difference, it was a bit we didn't have much of an option, but I think it's nonetheless it is definitely worthwhile. And thank you for your participation, and enjoy your weekend. Thank you all. Bye-bye.
Thank you. Bye-bye.
Thank you.